hypertensive, presented with NST-MI with normal LV function. Angiogram revealed critical LED diagonal bifurcation stenosis with Medina 111 with the syntax score of 11. Today's plan is image-guided stenting of diagonal bifurcation.
Why?
Yeah.
Give me why. Back end.
Root end, opposite end.
Yeah. Back end.
Back end.
Yeah. Back. And with the one through here.
Yeah.
One through. Yeah.
Run.
2, 1, 2.
They run through one.
Okay, can I do an RAO?
RAO?
Yeah. RAO cranial. You see the angiogram yet?
Yes, now we can see it.
Okay, now we will give some history. Give me 1 second. I need to.
What history already given?
Huh?
History is.
We already heard the case history.
Oh, you did?
Yes.
Oh.
And in fact, the looks like the lesion is a little bit less angry in compared to the diagnostic angiogram.
You hear the history, but I did not. Okay. Take a test. It's good. Okay, good. Ready?
Yeah, ready. Okay.
Okay, good. Now, okay, so you see the 2 angiogram. One's an RAO view, one's an RAO view. What do you think, panel? I mean,
it's a true bifurcation case. 0, 1, 1, 0 in area of cranial.
111 lesion. Good. True bifurcation.
1, 1, 0.
110. Let me see. Actually, the LAO view is show 111. Before, we can go over a little bit. We can show you the LAO view a little bit. So my plan is to wipe both lesion, both vessel. So we balloon that and IVUS it, and then we decided what kind of technique we're going to do. Okay. All right, let me go take this vessel first. That's okay. Now, can I have a second line?
Yeah, it's ready.
So, any particular choice of wire that you prefer in this situation?
I do a run through at this moment. Is any wire you suggest? Okay, good. Okay, thank you. The workhorse wire for me is a 1, 2.
Yes, so workhorse wire is good. Generally, I do 2 different color wires, so I don't make mistakes. So I use like a Pro Water and run through.
Pro Water, I see. Can I do the aerial view?
Hello.
So I think one's a LED, one's a diagonal. Or there's a dual LED system. I don't, whatever you want to call, both vessels really similar size. Okay, so these are LED. So let's so let's put a balloon.
Balloon.
So I like the balloon first, and then we can get an imaging. Then we decide what is the next step. So can we show the aerial view one before? So I think there's a 111 lesion, right? So if there's a 111 lesion, I think the vessel is a big diagonal or dual LED. So I think I like to do a two-stent technique in this situation. What do you think, panel? One
Why-
stent or two stent? The question is.
So why not keep it provisional? The lesion, even if it is there, it is very short and just limited to the ostia itself. So why not keep it provisional only?
Why not provisional? Okay.
I probably lean towards doing two-stent technique because of the length of the vessel.
What length you use?
Because of both, as you said, it's a dual LED kind of a system. So I would plan to do two-stent technique up front.
Yeah.
How about you?
Okay. Yeah, this I'm planning to do two-stent technique. I think this vessel, the side branch are very big, very important. The
So-
criteria I use for two stent versus one stent is one is the length of the lesion of the side branch is a more than 10. In this situation, it's not. Another one is using the definition criteria, which we did that before. The complex lesion need complex strategy. Yeah.
How about a stent in the main branch and a drug-coated balloon in the big diagonal as a provisional strategy? I mean, I think ordinarily, Taka, with you, we would all have, in the US, probably have done a two-stent approach here, but now with the DCB availability, maybe I ask my colleagues on the Indian side of the panel, DCB in the diagonal?
Yes, certainly. I mean, even if not DCB, then I would probably do it with a kissing balloon, final kissing balloon, and provisional stenting only for diagonal.
So I think the imaging will help us. If we look at the definition criteria, the side branch length, disease of the side branch, I don't know how long that disease is. Probably if we image IVUS down the side branch and we see the plaque burden of the ostium, if we do have IVUS, that's what we would do. I think that is one way of doing it. But you can't argue with somebody who wants to use a two-stent because it's an important and a large branch. At the same time, we know that less metal is actually not too bad in the long term as compared to two stents. So if he's a young patient, I would try to use one stent. If he's an old and he's got, the
discussion, yes, there's still a lot of discussion. For the bifurcation approach, after 20 years, everyone's still talking what we should do for a good result for the bifurcation. I'm sure you know the recent study about the bifurcation, the DCB trial for the side branch. Is LED. Can I have IVUS?
Yeah, I was in LED or
Both. Okay, let's do a diagonal first. Okay.
I was
And the results are pretty good. When you have the DCB, the side branch, and the stent for the main branch. And this is a patient, actually it's a simple lesion. It's a simple provisional lesion. The intention is to never do a two-stent in beginning. So they only compare the DCB and the regular balloon. It's not compare the two-stent technique. So we had to make aware of the child, what kind of population they are. Okay. Yeah, this is somebody said that there's a very big side branch, correct. So the side branch is only one diagonal in this artery. This is a major diagonal. So it supplies the myocardium definitely more than 10%. So make this one is very important. Can I see the imaging live? Live imaging? Live the IVUS? IVUS. Oh, good. We can pull back here.
Here is the diagonal, right?
Yeah, we are diagonal.
Here
Okay, can we do that? Can we pull back?
Yes.
Yeah, can you start it?
Brush. Okay, yes.
So you
Yeah,
pull
diameter
back.
is 2.75, right? Yeah, no disease
1, 2,
here
3.
in the diagonal.
Two,
Nearly 3, right? and coming the branch, you can see the guide wire here. So just the bifurcation, we have a disease, right? The diameter here might be more than 3.5, right? And very eccentric calcium.
So
Right.
possible LEDs are
LED,
1, 2,
yes,
3, 4, huh? 3, 5,
Yes.
4.
1, 2, 3, 5, 4.
Four.
Yeah. Media to media around 4.
Okay.
Right. Here comes the branch.
Now go to the left main now, right?
Yeah, bifurcation, right?
So left main looks
Left-
okay.
left
Stop
main-
it.
Left main.
Okay, so
I highly recommend to do the LED
let's see the
IVUS.
LED.
LED IVUS as well.
Yeah, I'm
Yeah.
doing the LED iris now.
Yeah.
So the diagonal, can you see the plaque morphology?
Yeah.
Any calcium or what?
Yeah.
Not really.
Distal portion of the diagonal, this is the mid portion, there are no disease at all.
No disease, right?
No
Very
disease.
clean.
Only a small amount of atherosclerosis. But here is the bifurcation. Just
See, the
bifurcation.
ostium is
I think orifice
Absolutely.
is no disease. There's a lot of disease in the LED.
So
Billion.
diagonal, no
Diagonal
disease
is clean.
or disease?
I think so, right? I'm back to the, here is the bifurcation, right? Just the bifurcation. You can see here the wire in the LED. This one,
Yeah.
right? And then this is the bifurcation. Just opposite side of the LED. Small amount of disease, right? Atherosclerosis just here, but no disease. But lots of disease in the LED. Just after bifurcation here, the LED, right here, many disease. But it might be better to check by IVUS in the LED.
Yep.
Right?
I'm
Yeah.
doing it. So that's very, very good news. If the diagonal is not severe disease,
No.
and we can just do a provisional
Yeah.
in this case.
Yeah.
Strategy has been changed now from
Huh?
the decay crush, which was the first plan looking at the angiography. Now it is going to be changed to provisional one.
Okay, let's IVUS here. Can we? Okay, go.
Yes, little distal to the bifurcation, already some disease, but the plaque volume might be less than 50%, right? Yeah. Coming is a perforator, and here already lots of
A lot of
disease,
that,
right?
yeah.
And here is a bifurcation. Coming wire is coming here.
Yeah.
And just proximal side. Size is 1, 2, 3, 4, 1, 5, but huge disease, many disease. And this is another branch, right?
Yeah.
So the main disease of the LED is the opposite side of the diagonal, right?
So it's right here, still some plaque all the way to
Yeah, right.
the ostium or a little bit. It's not that bad, okay? Right here,
Yeah, this is the
Ostium
bifurcation, right?
left main is
Left
clean.
main is coming only a small amount. Here, yes.
Okay. All right, stop there. Right?
Yes.
So the LED morphology is still plaque, not too much calcium, right? I don't see calcium.
Not too much. Mainly small amount. Here is just approximate to the bifurcation. Here you can see the calcium in the 9 o'clock, right? But small amount.
It's
Yeah.
very tiny, yeah, calcium.
Yeah,
So
very
more
tiny.
like fibrotic plaque there.
Yeah, right.
So, Tak, tell us if you're changing now to a provisional approach, are you going to do a jailed wire or a jailed balloon or pull the wire? What's your strategy for this big side branch?
Yeah, I think it's a good point. What is a provisional? I mean, we can do a gel wire, gel balloon, gel microcatheter. But either way, I think it's acceptable. I mean, in terms of the data, we're talking the data, the wire, the provisional with a wire, of course, there are much more data than the balloon. The balloon, I think, is very good when they are the small vessels. maybe 2O vessel, that's excellent to keep it open. But if we want to maybe do a kissing later on, if we shift the carana, shift the plaque, then I think the gel white techniques are much better. I think Dr. Saito is not here, and he is the one invented the gel balloon technique. Oh, he's in there. So he can teach us the real gel balloon technique. But in this case, I think if I using only the gel white, I think it's a very, very reasonable. Okay, that is my approach. Just using the white, protect the branch and stand it across. So the stent size in LED stent size will be 3O. Dr. Akasaka.
Distal, yeah, okay. Wait a moment.
The distal to bifurcation.
Distal to bifurcation is around medial to medial is 2.5.
2.5.
Yeah, because the branch is so huge. So after branch, the size decrease suddenly, right?
Yep.
Can you try quarter size? 2.75.
Proximal to bifurcation is a big.
Very big, right?
It's a
How to measure, right?
Tak, just for practical purposes, so it was a very tight lesion. Did you give nitrates after the balloon and before the IVUS?
Yes, we give it nitrate. We can tell in the picture. We haven't taken a picture yet.
Right. And the proximal is the medial to medial is 4.5.
Let's give some nitro. Let's see. We can. Can they do an RAO view? Okay, RAO. Nitro.
So,
Are you treating the diagonal at all before putting the stent in, and why? If yes or no.
Can you repeat it? I cannot hear.
Are you treating the diagonal ostia at all before placing the LED stent?
I don't think so. Once the IVUS showed that, the
already dilated.
The ostium is not that bad, so I think we can change our shape. Right, sir? Yeah. Okay.
I think the diagonal has already been ballooned once. Interesting choice for the stent.
So it should not be a problem.
Right? Sometimes it's better to take an intermediate size when the size discrepancy is a great deal between the distal and the proximal vessel. You take an intermediate size and don't blow it up to nominal. Go subnominal and blow up to a bigger size.
Is about 404, about 4.0 by IVUS, 4.2 by IVUS, and distal bifurcation is 2.5. But I think we can get a 3.0 or 2.75 by angio. 2.75 by angio. By how long is a chart? Can you say how long? About 20, 24, 28?
This might be the landing zone.
Yeah. Still some plaque there, but we can do it here. It's okay. Yeah, it's about less than 50 here. We can do it here.
23 or 28.
Wait a moment. Around here, maybe around 20, right?
23 is okay?
20.
23 is okay.
275,
275, 23. Okay.
should be okay.
So, would you like to predilate the proximal part of lesion a bit more, because there is a large vessel plus a lot of plaque burden also, although it is not fibrocalcific, but still, would you like to test it with a slightly bigger balloon, say 3 or something like that?
The ostium is okay, right? The ostium or the LED?
LED here, right?
I don't see, yeah.
Nothing, okay. It should be okay, right?
Yeah, I don't need
275, 22.
22 is fine.
Tak, do you have any preference for protection of the side branch, particularly preference for the stent? Some stent, does not protect it well. Some stent, they protect it well. Do you have any choice?
tell you the truth, I don't have any particular choice for all the stent. The expansion nowadays, I think if you have 2.5 stent, you can expand to 4.25 most of the time. So 275 stent, I think is a very similar platform. What do you think? You like science stent? You can expand better.
Not about expansion, like about the plaque shift and creating more problem for the side branch.
Oh, this one I don't have any particular interest. I mean preference or anything. So which one do you think is a less plaque shift?
So I think the laser cut stents are slightly better for side branch access as compared to the others. But as he said, all the stents are pretty good now for side branch access. Not much difference between one or the other.
And Tak, one more question, just planning ahead. When you think about proximal post dilation, proximal optimization, do you think about that, Tak? Do you think about how much proximal stent you have per pot?
And then the pot is very important.
We go to get a 4 part, the 4 proximal, 408 NC, 406. 6 or 8 balloon, NC balloon.
So Tak, walk us through your technique here. Are you going to check the side branch now and rewire it, or are you going to do a pot first?
I do a pot first. I lift my wire to do a pot. I think some people take this out, but usually I leave it there. This is my landmark. Okay, get ready for picture. And what do you think your approach, your panel approach? Most of you lift the wire in or take it out?
I think it's fine if you keep the wire in. This stent was 23 or 28?
22.
22.
22.
4 wire. Yes.
So in the audience, how many would leave the wire in? So the overwhelming majority. And how many would pull out the wire before placing the stent? So the majority would leave the wire in and jail it.
Yeah, I think this is a good point. But sometimes really it's not 100% safe. It's some patient, I will take the wire out. In patient with a very severe calcified disease, in the LAD proximal LAD, for example, and you gel the long length. I mean, this one only is 8 millimeter, 8 to 10 is okay. But if you gel for long one, you should take it out. This when you, for example, you gel a 20 millimeter of the wire underneath the stent, it's very difficult to get out sometimes. With a lot of calcium, and there's a risk to break the wire. So in that case, I will take the gel wire out.
I routinely pull back my wire close to the ostia with the radio opaque part, because you don't need to leave the whole length of the wire in a side branch.
Correct. I think a good point. Okay, but this is take a puff again. So when you do okay, take a picture. When you do the part, okay, you got to do it right. You go up. Okay, right before the bifurcation, just or at the bifurcation. Okay. How high? 14, 10. Okay. So I need to go into the proximal edge, which is sometimes difficult for my eye.
Tak, is your guide 7 French guide?
It's okay, right?
Yeah.
Oh, it's good. Proximal. Yeah. It's a little bit more. Yeah.
So we're using a stent boost to position the balloon, is it?
It's
And
good.
does anybody have a preference as to which balloon you use depending on the shoulder of the balloon for the proximal optimization?
The balloon, what kind of balloon here? What brand? SMT. SMT is from where? Local? Domestic? Okay, okay. So it looks like the shoulder is not that bad. I look at that. Some balloon, you're right. Okay, some company, the shoulder, the dot is really, really not the same as a balloon. The edge, that really can create a problem. And this brand of balloon, I don't have the experience on that, but looks okay. The best part balloon actually is from China. There's a part called a part balloon, okay? And the dot really at the edge of the balloon, short balloon, 6 millimeter, and it's excellent for part. Okay, let's take a picture. Okay, good. Can I see one more?
Hello, cranial.
Yeah. Then we do our iris. Iris LED. Okay, ready? Okay. So, what do you think I should do?
So at what stage would we pull out the diagonal wire or recross it if you have to decide to do something?
I mean, do we want to do something?
Tak, will do you do kissing balloon always in this situation?
No.
So how do you decide in which case you will do and in which case you will not do on the
Correct.
basis of IVUS?
Correct. Okay. In this case, we might want to do a IFR, FFR guidance in this situation, because you can see the diagonal. There's some shift on that, but this one could be an artifact or could be not significant at all. Let me do a LAD pullback from the iris. Hopefully, I can see the ostium or the diagonal also. Then we can tell. Routine piecing is not a good idea nowadays to do the bifurcation provisional. There's some retros. Okay, good. Right. Okay, can you go?
But if you have OCT, you exactly know how many, what is the crowding, how many struts are there. Here in IVUS, at times it is difficult to judge.
Yes.
So how do you decide?
Correct. This is a problem for iris, but sometimes, hopefully, lucky we can see.
Edge.
There's no
right?
edge.
No dissection.
Okay.
2 point.
It's a 275 stent. Looks good. Looks expansion looks good, right?
Yeah, very good. 2.5, right? Here it's a little bit underexpanded, but okay. Here might be the branch. Right, the branch. Yeah, and wire is coming here, right? This is the proximal side. 1, 2, 3, 4. 1, 2, 3, 4.
So proximal looks okay.
Oh yeah, okay.
Okay. So the side band we cannot evaluate. Doesn't seem we see a lot of things. Okay.
Difficult by IVUS, but
If some nitro we can see.
You can even take one OCT run. This is,
Okay.
a teaching course, and then, the audience will come to know how do you differentiate.
So let me do some nitro. Let me recourse the Y. Let me get another one through Y. Okay. We might need to do the iris for the side branch to see, or we do an IFR, exchange an IFR later on. So can I have another one through? Another one through Y? Give some nitro.
Nitro. Run through wire.
So what do you think if I do the iris for the side branch, you think it's helpful? Dr. Agasaka, you think?
no, it might be very difficult because
go in?
Yeah.
So I need to dilate it.
Yeah.
So let's get one for one. So the reason I hesitate to dilate it, I see a lot of side branches like that. okay, it turned out to be not significant by IFR. The reason we don't like to do a lot of kissing nowadays, just looking some observation data when we analysis our DK crush trial. When you had the kissing, the maze is increased and the patient underwent kissing. Okay, good. Can I have that talk? Yeah. Okay. So I try to recourse it to the side branch and take the side branch wire out, and then we do a picture. And if still look bad, then we do a volume, and then. But I saw someone with the OCT machine here now. Yeah. So if time permitted, then I do some OCT run of the main branch to see, to learn about the side branch from the OCT. All right? But let me rewind it first.
Can we see the live fluoro, please?
Oh, can you get a live photo?
We can see it now.
Okay, so side branch, yeah, is up. Yeah. Okay, good. You give a nitro, eh? So we can do a picture. Okay, ready? Yeah. Okay, this is after nitro. I think it's not that bad. Okay, let's do an OCT for the, okay, the LED. This is LED. Right? This one, yeah.
Tak, in your experience, if you treated that conservatively and looked again in 3 months, would it look different?
My experience, when it look later on, it will be totally okay. It should not be anything. This looks like artifact to me. That's many years ago. Dr. Gu do this FFR of the side branch. This is a one he always give the lecture. Okay, so that this is most likely is not significant, and he's right. Ready? Yes.
It's remarkable that after so many centers doing so many studies on so many bifurcations, we still don't have a consensus on which bifurcation to do a kiss, which one to do a pot kiss pot, which one to leave alone. And everybody has their own views. And but we do know some things from the EBC that whenever we do a kiss, we do negatively impact the long-term outcome of the main vessel stenting. And that is a problem whenever we do a kiss.
That's the problem.
And that's the issue. So you're always balancing one against the other.
No good. Do one more. Did not trigger? Self. Too far away? before stop. Right?
Can we
How about
see
now?
the angiogram? Could possibly, acha, it's not on
Yes.
75.
Too deep. Okay, let me go back. Here. Okay. It's okay?
We're inside the stent, is it? Lens seems very close to the stent edge.
No, that's outside. It's outside, right?
Fantastic.
Okay.
That looks good.
Should be ready? Tell me. OCT?
Why we didn't see?
I did not see the OCT. Inject. Couldn't see.
Oh, we didn't. Oh,
No, because we're late.
yeah.
We're
we
late.
didn't see the-
We need to see the screen. Okay, let's. So let's move back here. Can we do one? Huh? Can we do it?
રજની એને કમાન્ડ આપવાનું કે એ કમાન્ડ આપે પછી તું આપ.
એટલે સ્ક્રીન નથી દેખાતી.
એટલા માટે એને કહે કે તને કમાન્ડ આપે કે કરો ઇન્જેક્ટ કરો ત્યારે કર.
બરાબર.
સ્ક્રીન પર નથી દેખાતું.
The catheter?
Yeah, catheter is good.
How about now?
Take out. More?
More?
Yeah. Okay.
Too much. Too much. So go back in. Yeah, how about here? This one should not be that difficult. Okay? You still okay?
See the catheter is out. Caudal view is just
Check if the guide is hooked because
The guy is okay, right?
you can just purge and see if you're getting clearance.
The guy sitting, yeah. We can inject it.
So you're doing a 54 pullback?
Yes, yes. We are planned to have, yes, 54 millimeter pullback.
So that's a great point because if one wants to see whether it's a link or a strut across the side branch, you need a 54
Alright,
pullback.
let's go. Ready?
Yes. Manual.
okay. Okay. Enjoy. You tell me.
Now inject.
Better.
No,
It's too late.
Why? Still too deep?
yes, because we have lots of a normal image
Yeah.
without stent, right? Too deep.
But we see a bifurcation, this one.
Yeah.
Do we see it?
We missed the bike.
Here, you can see the OCT, right?
Yeah.
Yeah, right. You start the
Why
pullback
so-
from here,
Why
right?
so deep?
Epicranial.
Yeah, right. And then stent is coming here, right?
So suddenly the curve migrate down. Let me see.
Yeah, it's too deep.
No, suddenly it's. How about now? Now should be okay.
Okay.
Right? Let's get this one.
Okay. Okay.
Yeah.
Ready? Pull back.
Still pull back.
Okay. Okay.
Still pull back.
Okay. Okay. Ready?
Calibrating.
Tell me.
Pressing.
Okay.
During injection, catheter goes inside.
When you inject forward,
Yeah,
the catheter
catheter
forward.
forward.
Yeah.
Yeah.
The catheter move forward. That's right.
Show me the bifurcation.
Oh, right here.
Right.
Okay, here's a bifurcation.
We will try to make a 3D reconstruction. Okay. Yeah, here is the bifurcation, right? Yeah, two links, yes, over, right? Try to check here. Rotate. Yeah. Yellow color is wire, right? Yeah. Can you understand? Can you explain a little bit more?
Yes.
This is the fly-through image, right?
And 11 o'clock is bifurcation?
Yes,
Yeah.
yes.
Yep. So, is the ostium looks, I mean, does not seem to be
Yes.
plaque shift here.
Yeah.
There's no plaque.
Just only, yes, 3 is, yes. Three cells can, yeah, overlay, right? Yeah. Yeah. 3, 4, right. So I think generally speaking, the side branch is okay, right?
Yeah. In this image, I can see the side branches.
Yeah. You can identify the wire 11 o'clock, right?
No.
For the side branch, right?
Correct.
And then, yes, here is the side branch. Okay. But I think fly-through image is very easy to understand for the beginner, I think. Yeah.
Sensei, we see the metal across the ostium. Is it possible to say if it is a strut or a link on the 3D image?
I can speculate, right? Here you have a link, right?
That's right.
Yeah.
That's right.
And
So
then might be the link here and here, right? And this might be the link here. Here, right? So link should be around here, I'm afraid.
So we can say that it looks mostly like a strut except for half of one link that's across the mouth of the diagonal.
Yeah.
Is that okay?
Yeah.
Yep.
And I'm just afraid too much, yes, bifurcation lesion treatment makes the deformity of the main vessel, right? So if you try to do the kissing, wire should be here or
Through the
here,
distal strut.
right? Here or here.
Correct. Correct.
Otherwise, I cannot recommend the kissing using this wire. Right. Because
Also-
if you do the kissing using this wire, this strut goes up to the main branch.
Correct.
Right?
Yeah. So this why if I want to do kissing, I need to rewire it inside and do another OCT. Make sure that inside that link, then do a good safety kissing.
Right.
Okay.
If we want to do.
Yeah, if you want to do it.
Yeah.
Now, in this case, we don't have the NGO FFR here, right? To do the FFR NGO, just by the angiogram.
Yes.
So you don't have to do it here. Okay. So if you want to do a functional test, we got to do an IFR or FFR. But in this case, I'm pretty confident.
So would you like to pull out the jailed wire and then do a repot? Sometimes we can push the strut away if you keep the marker 0.5 mm distal.
I think the more instrument here, you probably create more damage. If I do another part, okay, I might shift more of the stent link to that. So I'm not 100% sure I want to do that.
I think that's perfectly all right. I think it looks like a great result, and
Yeah, I think at this moment, I probably stop it. Okay, unless you guys tell me no, that's 100% we should do something. Then I will consider that. If not, I will definitely leave it alone. If we had the angio FFR nowadays, this angiogram can have a very reliable information about the function, about the physiology. And this case is a very good case when we do the angio FFR to show that do we need to intervene the side branch or not. But since we don't have that here, I think I will just finish it. I pull the wire out, take a picture, and see anything change. Maybe the wire causing more artifact. So, okay, let's see. Ready? Okay. All right. So we make similar. Okay. I think I leave it alone. Okay. Thank you very much, everyone.
great case. Thank you very much.